Uh, Bismillah ar-Rahman ar-Rahim. It's a great pleasure to introduce our first speaker in the first session, a new era in metabolic and genetic disorders. And Professor Jerry Buckley, he's a professor of human genetics, director, Center for Rare Disease Therapy, University of Pittsburgh, Pennsylvania, USA. He will give an interesting talk entitled mRNA treatment of inborn errors of metabolism. And actually, Professor Buckley, for some reasons, he's not available to be physically, but the talk will be virtual, but he will be active during the Q&A in the end of the second session, inshallah.
Hello, I'm Jerry Buckley, coming to you from Pittsburgh, Pennsylvania, in the United States, and I'm pleased to be able to talk to you, at least virtually, at this meeting. I think I'll be live with you after this for some questions, so hopefully we'll have a chance to talk then. Let me get things shared here. Yep, it looks like it's worked. And so I will start with telling you what I've been asked to talk about today, which is mRNA therapy in metabolic disease. Just one more line of introduction. I'm Chief of Genetic and Genomic Medicine here in Pittsburgh, and of course treat metabolic patients as part of my regular daily routine. Let's see if I can, I don't know if you're seeing that or not. I'm going to slide something out of the way for me. Here are my disclosures. Research funding. I'll just note that I do get research funding from Moderna for these studies, but no personal income. So the problem in inborn errors of metabolism compared to a blockage in a pipe. You can have two effects. One is a deficit in what's supposed to come out of the pipe, the water in your bathroom sink, or a problem related to what's backing up behind the block. So the water is now going into your basement instead of the sink. And either or both can lead to clinical symptoms. And when you're looking at options for therapy, here in this stylized diagram, what you can do, or what you can think of, the way you can think about it, is that you can. I'm looking for a. Hang on a second. That didn't work. Here we go. With this stylized, simple enzyme reaction here, a substrate going to a product, is that you can either replace the product if that's the problem, try to reduce the accumulation of the presentation of the precursor, or you can try to improve the enzyme activity either through gene therapy or a transplant as a replacement therapy, or in this case, mRNA therapy, and that's what we're going to talk about. I'm going to start off by looking at some work that I've done with mitochondrial fatty acid oxidation disorders, and I'm sure many of you are familiar with these, so I'll keep my introductory comments short. Basically, fatty acid oxidation is divided into two components. One is the long chain, which is about C10 or 12, up to C20, which is the usual, the longest naturally stored substrate. And then medium chain, which is C10 or 8 on below. And once the substrates get into the mitochondria, which uses a three-step transport system for long chain fats, but is probably passive diffusion for medium chain fats, you undergo this four-step cycle, starting with acyl-CoA dehydrogenase, and then three enzymes that for long chain fats are on a single protein, mitochondrial trifunctional protein, but for medium chain fats are individual enzymes. In humans, this is largely carried out for long-chain fats by very long-chain mucosal-coated dehydrogenase, and we'll come back to that in a second. Fatty acid oxidation doesn't work by itself. It requires two other cycles, metabolic pathways to generate energy. First is the respiratory chain, which is, of course, the pathway that makes the ATP. And on-chain fatty acid oxidation does make reducing equivalents that get passed directly to the respiratory chain, but it also makes acetyl-CoA as the end result of a cycle of fatty acid oxidation, which then goes into the TCA cycle and now generates the reducing equivalents that create the rest of the energy from a round of fatty acid oxidation. The main symptoms in long-chain fatty acid oxidation disorders are hypoglycemia, rhabdomyolysis, and cardiomyopathy. Although with isolated LCHAG deficiency, one of those enzymes of the trifunctional protein, you also get peripheral neuropathy and retinopathy, and in the whole trifunctional protein, you get peripheral neuropathy. Medium chain acyl-CoA dehydrogenase is really a liver-based problem. And you end up with hypoglycemia, hyperammonemia, probably a secondary imbalance in the urea cycle. And so these folks don't get the cardiomyopathy and the skeletal muscle abnormalities. You can see here in this diagram that SCAD, MCAD, and LCAD are homotetramers depicted over here, whereas VLCAD and ACD9 are homodimers. I don't have that shown, but it's basically half of this molecule, and an additional 880 residues on the C-terminus that helps to stabilize the dimer. So the primary defects that we're going to be about here today are VLCAD deficiency and MCAD deficiency. Of course, there's a therapy for long-chain fatty acid oxidation disorders, triheptanone, which has now been approved for almost 5 years in the United States. And it is overall effective. It reduces in long-term follow-up studies the number of metabolic events, the hospital days, the number of hospitalizations, and it decreases both hypoglycemia and rhabdomyolysis, and again, cardiomyopathy represented here, but it also works very well there. But it's less well, it works less well for rhabdomyolysis, and so there's still a need here. And to help us develop those, we really need to drop back for a second and create a new mouse model. And the reason for this is that long-chain fatty acid oxidation, unlike in humans, in rodents relies both on VLCAD and LCAD. And so if you just knock out one, you don't end up with a very dramatic phenotype. Neither develop rhabdomyolysis. They get irregularly cardiac symptoms. And they don't have a very significant myopathic picture. So what we've done is we started out by seeing what would happen if we just knocked both out of the mouse, and it turns out that that's lethal. The mice don't survive. Occasionally a live animal is born, but it dies within hours. And so instead what we did was we knocked out, because we were most interested at the start of this in the rhabdomyolysis, we knocked out LCAD gene in muscle in the background of VLCAD deficiency. And so now we have a double knockout in muscle, a single knockout in everything else. And it turns out that this animal not only develops the rhabdomyolysis, it has a severe myopathy, and it starts developing cardiomyopathy. It actually gets that by 2 months of age, and it reliably does that for every animal. So it's in spite of the fact that we just knocked out the LCAD in the muscle, we're getting systemic effects by that. So let's take a look at mRNA therapy. I guess the first question we should address is, why would we do mRNA therapy for systemic disease? You might know that mRNA currently is being delivered by lipid nanoparticle nanoparticles that are targeted almost essentially completely to the liver. It's very hard to get them to other areas in the other tissues in the body. But based on the fact that knocking things out in muscle created systemic problems, maybe just improving the liver would help. And remember, so that there are the triheptanoin is not fixing everything here. So we did that. We got an mRNA from Moderna, and if we injected it in the animal, we not surprisingly in the liver make mRNA and fibroblasts. We can show that the VLCAD is going to the right place. Here, VLCAD staining. Here, another mitochondrial protein staining, and here overlapping the signal. You can see that it's yellow, indicating that these two signals are localizing to the mitochondria. This mRNA that we inject lasts at least up to 144 hours at a level as high as a wild type. And compared to other mRNA therapies tested in animals like MMA and PA, this would suggest that about an every other or maybe every third week injection would be enough to maintain this level. This protein is active, as you can see here, leading to very high levels of enzyme activity. So what is the systemic effect of this? Well, one of the most dramatic deficits in these animals is that they're cold intolerant. If you take a wild type animal and you put it at 4 degrees, it just runs around and lasts forever. However, if you put one of these animals in the cold, it gets hypothermic and it becomes lethally hypothermic by 3 to 4 hours. If we inject them with mRNA, VLK mRNA, here half of those, here full dose, what you can see is now you start improving that. And in fact, this animal, although it has some reduction in temperature, can survive long term now in this environment. If we look at the ability of these animals to run, not surprisingly, they're fairly impaired because it's a muscle knockout on top of an LCAT on top of the full body knockout of the VLCAT. And while a normal mouse on a treadmill running can go essentially forever, we stop it at 400 meters. If we run these animals for the maximum time, 40 minutes, they barely get to 40 meters. And this is at a reduced speed, in fact. So they're very impaired in their skeletal muscle output. Treatment with triheptanoin helps that by a little bit, but not by a lot. But if we give them mRNA therapy, liver-directed, remember, what you can see is that there's a significant improvement in analytic distance here. These animals are now running almost 300 meters compared to the less than 40 that these guys are doing here. And this experiment, they happen to run a little bit more on average. It turns out that that's about the same as if we give them an AAV-based VLCAD gene therapy that we can develop. And these animals will run the 400 meter distance that the wild type animals do. And that's not too surprising because this is an AAV9 vector that does express both in heart and in skeletal muscle. What is that? How does that translate into improvement in the rhabdo? Well, you can see here, if we run these animals, first of all, they have baseline rhabdomyolysis here. You can see 2 different groups. However, if we run them, that goes up dramatically. And if we give them C7, it really doesn't change very much. However, if we give them mRNA therapy, here you can see these are the animals. This is a previous these guys developed levels of about 2,500. Here with mRNA therapy below 1,000. Here in gene therapy, a very similar difference. So just fixing the liver has a significant systemic effect in these animals. We can express cat mRNA just to show you here. We had a couple of different mRNAs. This would work pretty well. This is a liver signal. Here, fibroblast signal showing that overlap with the mitochondrial marker protein and high levels of MCAD in muscle or in liver compared to wild type. Interestingly, this particular lipid that was being used, it was a different generation lipid, did manage to get some expression in muscle or heart, but we haven't been able to reproduce that with any other mRNA. We tried to put the VLK mRNA in the same lipid and it didn't work. So this is something idiosyncratic with this particular mRNA and lipid, and otherwise would have been a terrific candidate for moving forward. But we're not going to do anything with this in terms of human treatment. I just don't think there's a need for it in MCAD deficiency. Let's look at some other therapies that are out there. Moderna has a propionic acidemia trial in progress, and if you look at the early phase 1-2 dose escalation, what you can see here is a red dot these are cohorts of small cohorts of patients, 3 to 4, and these red dots indicate an episode of metabolic decompensation, basically. So you can see here early on, prior to treatment, there are lots of red dots, and that with increasing dose here, lower down on the graph, what you can see is that the lower doses, with time, what you get are maybe a little bit of decrease, but down here, as you get up to closer to what's used the therapeutic dose, there's a very, in this case, actually no episodes of metabolic decompensation reported for these last 2 cohorts. So even though this is a systemic disease, as with liver transplant, which decreases episodes of metabolic decompensation, giving high levels of mRNA also seems to be working in this condition. This study is ongoing. The doses are now at higher levels. The patients are being treated for longer periods of time, and we'll see how that works. There are other mRNA therapies in development. This isn't an exhaustive list, but I mentioned methylmalonic acidemia. That's the mRNA treatments that are either in late preclinical or early clinical trials for acute intermittent porphyria, Gray disease, ornithine transcarbamylase deficiency, citrullinemia, PKU. So we're going to be seeing lots more of this coming down the road here in the not too distant future. So, in summary, mRNA therapy for metabolic disorders is expanding, is limited by tissue expression, and the current best uses are for liver-based disease. But there are some systemic effects, as we saw in our LCAT double knockout mouse, where we were able to improve rhabdomyolysis and running very nearly the same as with gene therapy. How will this be used in clinical practice? Well, it really remains to be seen. It's going to depend on how frequently these injections need to be done. If they need to be done every couple of weeks, then we'll view it as similar to current enzyme replacement therapies, and use it similarly. If it can be extended to a longer period of time, say once a year, twice a year, then it becomes a viable long-term therapy. But at the very least, one can think of this as a potential either as a rescue therapy or a bridge therapy to a definitive therapy, such as gene therapy or liver transplant. Think about an acutely presenting neonate with OTC deficiency. You could give them mRNA therapy every couple of weeks to stabilize them until it's long enough until they're able to either undergo a definitive gene therapy or liver transplant. I can see the same thing happening with VLCAT deficiency, where you use the mRNA therapy for a couple of years to get out of the youngest age range, where we feel a little bit more comfortable potentially going to a gene therapy. So with that, I'll say thanks to my lab and acknowledge my collaborators, and thank you for listening. And let me get out of sharing. There we go. I'm back on camera, I think. Thanks for listening, and I hope that I'll have the opportunity here right after this to go ahead and take questions. Thanks and goodbye.
Actually, I want to thank Professor Vockley for the great talk. And now it's a great pleasure to introduce the second speaker. Please, Professor Aizat Al-Sabki, Professor of Medical Genetics, Medical Genetics Department at Ain Shams University. He will give a great talk about PGTM for the diagnosis to management. And actually, for some issues, we miss Professor Aizat today. He will present it virtually. Please, Professor Aizat, the floor is yours.
Good morning, everybody. I'm very sorry not to attend physically in this elegant meeting. Yet I actually am able to give this presentation through the Zoom. So I am going to give a very short story of the pre-implantation genetic testing, or PGTM, and we'll start by very basic information, then we'll go one by one. Next slide, please. Actually, our main aim as a geneticist is a prevention genetics or preventive genetics. The ultimate goal of medical genetics is to improve the health of well-being of individuals. And this is, we do it perfectly, actually, in our department, the medical genetics department. We do the best and we give the best care for each individual patient. And this is the best care for individuals. Yet, we have to be quite aware of giving the same care for the family and the community and the society at large. So my way of thinking is to give also similar care for the family and for their dreams. Next slide. If you think about the genetic disorders, they do have actually a chronic lifelong impact on the individuals and on the family and the society. If you think about Egypt, we have a very limited facilities. So actually, although we did a great effort to give the best care, yet the limited facilities would end up with suffering families. Next. The only way is to limit the number of cases. And that's why the preventive genetics is to try to reduce the number of suffering cases. Next. So the medical geneticists actually are doing a great job. And they go through a lot of files and they listen to the patient and collect all the data and start to do a family pedigree. Then by family pedigree and a great clinical assessment, in most of the cases, we have a provisional clinical diagnosis. But this professional or provisional clinical diagnosis would actually need very, very specific investigations to come out with a definite diagnosis. When you have a definite diagnosis, this is the only way to offer the family what we call it evidence-based counseling. So if you have in your hand a definite confirmed diagnosis, you can offer the family genetic counseling, evidence-based genetic counseling. Next. Yet recently we have a very rapid progress in the available diagnostic technology and its impacts on the changes in the genetic terminology. Next. So the investigations at the molecular side has improved from single gene targeted sequencing. That's a long time ago. We have to think clinically that this most probably the gene responsible. And you ask for targeted sequencing of this gene. If the result comes back as normal, then you think about of alternative possibility and to offer another gene for sequencing. Yet now we have what we call it a clinical exome, that you think clinically and you can offer not whole exome sequencing, rather you offer a clinically oriented exome sequencing. But again, if you don't have a clinical clue, you can go to a whole exome sequencing. If the whole exome sequencing came back as normal or VAS only, then you may think about the whole genome sequencing. And nowadays, in each and every part of the world, you can offer carrier screening with the increased level of awareness among the population. So the couple premarital may ask for a carrier screening. Next. On the other hand, the progress in the terminology of the pre-implantation genetic diagnosis, it changed recently, almost 5 to 7 years ago. The International Society of Pre-Implantation Genetic Diagnosis, although it was classified as a pre-implantation genetic diagnosis and pre-implantation genetic screening, PGT and the PGS, nowadays and recently the terminology of PGD changed to PGT, and T means pre-implantation genetic testing. So you have to verify, is it pre-implantation genetic testing for aneuploidy, that means chromosomal abnormalities, or PGT SR for structural rearrangement, if you know that this family has a specific chromosomal translocation or inversion or whatever, so you ask for PGT SR. But if the problem is not related to the chromosomes and it's related only to monogenic or single gene disorder, then we call it PGTM. Next. So PGTM is the pre-implantation genetic testing for monogenic disorders. And this is our main subject of the discussion today. Next. Actually, we have to realize that our clinical genetics team is doing actually a great job. And this great job is actually by, as I said before, collecting all the history and data and making a very explanatory family pedigree and you have in your hand a possible clinical diagnosis, but you have to investigate and then you come out with a proper molecular diagnosis. Next. So when you have a proper clinical diagnosis, you meet the family, and then the family has several questions. Is this actually a genetic disease? And if this is a genetic disease, is it possible to come back in the next pregnancy, the recurrence risk? And if this recurrence risk is like 25%, 50%, or even 3%, should we go for prenatal diagnosis or for pre-implantation genetic diagnosis? So actually, we have to answer to the family what their next plan for the next pregnancy. Next. So the first question to answer after evidence-based counseling, that this is the genetics, and the recurrence risk is exactly 25 or 3% or 50%. And you have to tell the family, you should know that we have a preventive scenario for you. So this scenario could include prenatal diagnosis and or pre-implantation genetic diagnosis. And for the family to take a decision, they have to know the advantages and limitations of each possible reproductive option. And these are the reproductive options, the prenatal or pre-implantation diagnosis. Next. So although we explain everything and we explain the benefits and the limitations of each single possible reproductive option, yet the final decision should be non-directive decision. You explain, you answer everything, but let the family to take their own decisions. Next. So you have two reproductive options, as we said, prenatal diagnosis or pre-implantation genetic testing or diagnosis. Next. By prenatal diagnosis, you have to wait for like at least 12 weeks of pregnancy to take CVS or chorion villus sampling, or up to 15 or 16 weeks to take amniotic fluid. And by these two techniques, your aim is to have a fetal DNA. So if you have a fetal DNA, then you can offer the proper testing based on the family decision. But they have to realize that this is an invasive technique, and the result will come back after like 2 to 3 weeks, and they have to admit and agree if they have an affected or diseased pregnancy or fetus, then they have to be ready to take their own decision to complete the pregnancy or to terminate the pregnancy, considering all aspects of the disease and the outcome of the disease and the religious belief for this family. Next slide. The other alternative is to arrange for IVF or ICSI, which is intracytoplasmic sperm injection, and by the day 5, nowadays, recently, by the day 5, you have a trophoctoderm, and you take a plastomere or trophoctoderm biopsy, and you freeze the embryo itself. When you take the trophoctoderm biopsy or the plastomere biopsy, then you extract the DNA. So in prenatal, you have the fetal DNA. And in pre-implantation genetic testing, you have the embryo DNA. Next. So if you have the embryo DNA, then you can offer PGTM or pre-implantation genetic testing for monogenic disorders. And you have to realize that PGTM actually started in 1990, almost 35 years ago. Alan Handside in England has decided to offer PGTM for 6 linked genetic disorders. And at that time, he offered them PCR for the one only. So he would exclude the embryos carrying the Y signals using the PCR. Then after that, he offered PGTM for cystic fibrosis. So the story started 35 years ago. It's not very recent. Next slide. And if you think about Egypt with a very high consanguinity level, so most of the couples attending the medical genetics clinics have positive consanguinity. And we have to realize that consanguinity in different parts of Egypt may go to up to 50% of the couples are consanguineous. And if you think of autosomal recessive disorders, and on the other hand, you think about the religious consideration or limitation of possible pregnancy termination, so actually PGTM should be considered as an excellent approach to primary prevention of monogenic disorders. And in fact, practically speaking, when you meet the families who have affected kids and then you offer them the proper counseling or the proper diagnosis, in my experience, that was the favorable choice of most of the suffering families. Next slide. I don't have to go through this slide because monogenic disorders, as a geneticist, you know that this could be autosomal recessive, including beta thalassemia, SMA, cystic fibrosis, all inborn errors of metabolism, and I will not say all, but most of inborn errors of metabolism, Fanconi's anemia, and I'm listing here the most common autosomal recessive disorders in Egypt. For autosomal dominant disorders, neurofibromatosis, tuberous sclerosis, Marfan syndrome, achondroplasia, and Huntington disease also. For the X-linked disorders, you have hemophilia, Duchenne muscular dystrophy, Fragile X, Rett syndrome, and others. And on the other part, one of the indications for PGTM is adult onset disorders, including cancer also. Next slide. Next slide, please. When you offer PGTM, we have to know that we don't directly test the underlying monogenic variants. Because if you only test directly the monogenic variant, you may end up with a false results. And this is due to what it was called allele dropout. And the allele dropout has actually led to definite problems in certain PGT outcome. So nowadays, you do preclinical testing or setup for the family using SNPs or STR. So you use DNA markers and you set a specific setup for the family. So you test the embryos for the specific variant, and also you include the linked SNPs or STR. Next. Next slide. And here you can realize if you offer a PGTM for SMA, and you all know that SMA is actually one of the common single or monogenic autosomal recessive disorders. So as you can see in here that you know the actual deletion of SMN1 here and inside this oval red sign, but you take before and after and closely linked markers around the SMN1 and SMN2. And these linked markers would move with the SMN1 while the segregation of SMA. So this is what I meant by family linkage study or preclinical testing or preclinical setup or haplotype identification. So based on the markers, you have a high risk haplotype and low risk haplotype. And this step actually takes time. It takes like 4 to 6 weeks. So before the definite PGT-M testing. Next slide. And this is the case of methylmalonic acidemia after offering PGT-M and including the pre-clinical testing and the actual PGT-M, then you end up with, if you examine like 10 embryos, you know that these 1, 2, 3, 4 embryos are quite normal, and the other embryos are carriers. So you, the family know that these are the normals and those are the carriers. So they select which embryo should be transferred after testing. And you avoid actually, so from the day one, you know that the pregnancy is actually normal. Next. So if you think about PGT-M or pre-implantation genetic testing for monogenic disorders in IVF centers or after ICSI, so you have to realize that actually 80% of PGT-M cycles resulted in embryo transfer. What I mean is, if you arrange for IVF and PGT-M, in 80% of cases, you will have embryos for transfer. And about 30% of the embryo transfer will have pregnancy, and about 40% of embryo transfer would have implanted and they have successful pregnancy. The liability of possibility of losing this pregnancy or miscarriage is within 10%. Next slide. So we have only like a couple of minutes, that's it. So actually in Egypt, the PGT-M program is improving and we have excellent results. Next slide. There are some challenging implications for PGT-M. We don't have time to discuss it. Next. In conclusion, PGT-M, you go for genetic counseling, clinical diagnosis, molecular diagnosis, and so you have evidence-based counseling. You offer them and you explain everything for their reproductive options. Next slide. After of doing all the tests, if you have 10 embryos like that, you can say that this embryo number 1, number 5, and number 8 are normal. So the lady will only transfer the normal embryos. Next slide. So I have to tell you that actually this boy was a product of PGTM, and he is now 8 years old. And then this family had more than one normal embryos. So the embryo transfer 9 years ago, they have this boy. Then actually after 3 years, they decided to embryo transfer another embryo from the tested embryos. So they have another boy who is now 5 years old. Next slide. And this week only, in April 2025, the family from Libya sent me these 2 photos that they have a very successful pregnancy, and they have 2 newborn. Normally, from this family, the family was suffering from rhizomelic chondrodysplasia punctata. They came from Libya. We offered them molecular testing. We offered them genetic counseling, and we offered them PGTM, and they sent us these 2 photos from Libya. And thank God, our effort is successfully doing something in prevention genetics and giving a smile for this family. And next slide. And I have to say that we are a group of medical geneticists with technologists, and our number is almost close to 100 personnel offering this great job in Egypt. And thank you for listening. And I'm very sorry to extend my time for 1 or 2 minutes. And thank you very much.
Thank you, Professor Izzat, for this very interesting lecture. Are you still online?
Yes, sir.
Good morning, and hope the best for you. We missed you a lot. We needed you to be present with us. But actually, next time, inshallah.
Inshallah.
Do you think that this form of PGTM reproduction should be normal for any couple with a monogenic disorder? I think it's a wonderful option, and it solves the problem and the pain and tears and everything. But the problem is it's rather expensive.
Yeah, definitely. Everything. First of all, thank you very much, Professor Ahmed. You are doing a great job also, actually, in selecting cases.
Thank you.
And you are the man behind the prenatal diagnosis in Egypt.
Thank you.
And so we are moving together. And I know that you are offering now PGTM
Yes.
in different IVF
I
centers.
find it very interesting
know.
and problem solving.
Yeah.
So, thank you, Professor. Any questions?
Yes.
Audience?
Could you please make it to the end, because we have
Okay.
to.
Thank you so much. Thank you, Professor Izzat.
Thank you very much.
Bye-bye. Now we will have another online session. Dr. Thomas White, he's the lead field medical director. He will give us in Pennsylvania. The talk title is Gene Editing Approach for OTC Deficiency. Professor Thomas.
Hi, everyone, and thank you to the meeting organizers for inviting me to speak to you all. Apologies for not being able to be there in person in Cairo, but hopefully another time. So my name is Tom Lane. I'm a field medical director with EUCure Inc. We are a small biotech based out of the Philadelphia area, and currently we have an investigational gene editing therapy, EUCure 506, which is being evaluated in a clinical trial for severe neonatal onset OTC deficiency. For my talk today, I'm going to give a quick overview on neonatal onset OTC deficiency, and follow that up with some gene therapy approaches that are currently being utilized or investigated in the world of inborn errors of metabolism. And then the last portion of the talk, we'll go over some of the preclinical data that we've accrued with EUCure 506, which paved the way for our CTA90 clearances for our first in-human study known as the OTC HOPE trial. And we'll wrap things up by sharing some preliminary clinical data that we have in the trial with the first infant that we have dosed. So OTC deficiency is a severe, ultra-rare genetic condition. OTC deficiency is actually the most common urea cycle disorder. Still has a prevalence rate between 1 in 60,000 and 1 in 72,000. OTC deficiency can present really with a very heterogeneous clinical sequelae with these patients with neonatal onset OTC deficiency being the most severe form of disease. Typically presents within the first month of life and has been associated with mortality rates as high as 74%. Hemizygous males with limited to no enzymatic activity typically present with signs and symptoms within 48 to 72 hours after birth. And these signs and symptoms can include seizures, failure to thrive, irritability, stupor, early stage coma as well. Currently, treatment consists of nitrogen scavenger therapy as well as severe protein restriction. The only curative therapy currently available is liver transplants, typically required by 6 months of age for the severe neonatal onset form to prevent further neurological decompensation. So how's OTC deficiency currently diagnosed? Well, here in the States, currently only 7 states have OTC deficiency as part of their newborn screening program. And this is because really there's no single analyte that is perfect for detecting OTC deficiency. A lot of these newborn screening tests are centered around low citrulline levels, which can have fairly poor sensitivity for OTC deficiency. So really this is where the importance of recognizing these early signs and symptoms of neonatal onset deficiency become absolutely paramount to ensure that a plasma ammonia level is ordered. This is really typically the first step of diagnosing these severe neonatal onset kids, and then have confirmatory genetic testing take place thereafter. Carrier testing, prenatal diagnosis of OTC deficiency is also possible as well. So there are several gene therapy approaches that are currently being investigated or utilized for inborn errors of metabolism. The first being mRNA therapy. The first being mRNA therapy here on the right, in which an RNA payload enters the cytosol, protein translation can occur. So this is essentially a protein replacement therapy. This is mutation agnostic, but non-durable. This requires frequent, approximately bi-weekly IV infusions for administration due to the short half-life. Next, we have gene addition or gene replacement therapy, in which a transgene is administered to these patients that enters the cells via typically an AAV carrier, and then this transgene essentially forms an episome or freestanding circular strand of DNA, which then can start production of the protein. This is mutation agnostic. However, there is durability issues when treating newborns. This goes to show that there is episomal dilution that can occur, which I will show in the next slide. Next, we have base editing, which corrects a single variant error. within a genetic disease for a disease like sickle cell, where there's one mutation responsible for approximately 7% of cases. This is a great option for a disease like OTC deficiency. This isn't very effective, as OTC deficiency has over 400 known variants. And then lastly, you have the gene knock-in approach or gene insertion approach, which we're utilizing at EOCure. This is both mutation agnostic and yields durable and permanent gene replacement as the transgene is becoming fully integrated into the host genome. So again, just highlighting the differences between gene addition or gene replacement therapy compared to gene editing, especially when thinking about mitosis. So on the left-hand side here, you can see a non-integrated transgene set up in the form of an episome, which is not integrated into the host genome or into the chromosome. Then as a cell divides, you can see only one of the two daughter cells maintains this functional transgene in the form of an episome. And as further rounds of mitotic division occur, you can see eventually how this transgene effect can get diluted out, and you can have loss of clinical benefit with gene addition or gene replacement therapy. On the right-hand side, you have gene editing approach, in which there's a fully integrated transgene into the chromosome. As you subdivide, you do not see loss of effect. And this yields long-term expression due to site-specific integration of the transgene. This is how the EOCure 506 platform works. We're utilizing a dual AAV vector. We're utilizing AAV RH79. And this was chosen intentionally by the Penn Group. So all our preclinical work was completed out of Dr. Jim Wilson's lab at the Penn Gene Therapy Program. AAV RH79 was chosen intentionally over AAV8 due to AAV RH79 being more hepatotropic, so delivering more of the payload directly to the hepatocytes, which is where you want this therapy to go. One of the AAVs houses a nuclease, and the other AAV houses a therapeutic gene. And this is a 3-to-1 ratio in favor of the therapeutic gene. The nuclease we're utilizing is the ARCUS nuclease, which I'll give in more detail in the next slide. ARCUS was chosen over CRISPR for a variety of reasons, which I will get into shortly. So the ARCUS nuclease has the ability to seek out and target a specific 22 base pair sequence within exon 7 of the PCSK9 gene. So we're targeting the PCSK9 as a safe harbor gene, as it is both well characterized and non-essential. So once this double-stranded DNA break occurs within exon 7 of the PCSK9 gene, the other AAV vector housing the OTC transgene cassette can then become integrated at that cut site. So ARCUS is not a very well-known nuclease. Everybody knows about CRISPR-Cas9 in the audience, which is really most typically used. But ARCUS was, again, chosen intentionally over CRISPR for this program. This is because ARCUS is smaller than CRISPR, so it can be packaged within an AAV capsid. And ARCUS does not require the addition of a single guide RNA like CRISPR does. ARCUS can actually reprogram itself to seek out a specific 22 base pair sequence and cause a double-strand break. Also, the type of cut the ARCUS makes is different compared to CRISPR. So CRISPR makes a blunt, straight cut within the DNA, whereas the ARCUS cut results in this uneven 3' and 5' overhang cut. Which Precision Biosciences, who produces ARCUS, has published some data showing that this type of cut encourages homology-directed recombination. So all the preclinical work, again, was done out of the University of Pennsylvania. So the first preclinical study was really a proof of concept study, and this did utilize a different cassette that we're utilizing in our clinical trial. I'm going to highlight that. So this utilized AAV8 and CRISPR-Cas9 in a mouse model. But this study really proved or demonstrated that editing can mediate molecular and biochemical correction in a mouse model of OTC deficiency. So quickly here you have the untargeted, the Schwarz rash disease mice, and then the mice who received the untargeted therapy or the gene addition, gene replacement therapy, and then mice who received the targeted edited therapy. So you can see mice who received the targeted therapy. This resulted in 70 and 70% enzyme production compared to wild type, which was both 2 and 3-fold higher at 3 and 8 weeks. 7 days after vector administration, all mice underwent a 7-day high protein challenge. You can see here the targeted group, mice in the targeted group had ammonia levels 60% lower compared to the sparse rash control group, and the untargeted group, or the gene addition, gene replacement group, there was no statistical significant difference between ammonia levels. And lastly, the mice who received the targeted gene editing therapy, where the vector has become integrated, had 100% survival. So this overlapped with wild type, and you can see the mice who received the untargeted or gene replacement, gene addition therapy did not have 100% survival after the high protein challenge. The next step the Penn group took was to assess how well ARCUS can seek out and knock down the PCSK9 gene. So this study was done in non-human primates. So you can see after administration of the ARCUS nuclease, this resulted in a pretty quick and durable reduction in PCSK9 expression. And the last preclinical step the Penn group took was really to assess how much of this how much of the vector from EQR 506 is becoming integrated into the host genome. And this is because there's not a disease model available in non-human primates, so you can't assess how much OTC enzyme activity has increased, but you can assess via additive how much of the vector is actually integrated into the host genome. So these apes were biopsied 3 months after vector administration and 1 year after vector administration. You can see 3 months after vector administration, this resulted in 14% and 16% transduction percentages. And 9 months later, you can see that this was a durable effect, yielding 28% and 20% vector integration within hepatocytes. As far as tolerability, we did see transaminitis occur approximately 1 month after infusion of EQR 506 is corrected on its own without administration of immunosuppression. So all that preclinical work gave way to our first in-human trial known as the OTC HOPE trial. And this is studying EQR 506 in newborn mouse with neonatal onset OTC deficiency. This is a global trial. We're utilizing 2 different protocols. So we have, based on discussions with regulators, so we have a US-based protocol, which we're looking to dose up to 4 babies and have 3 different dose levels that can be utilized. And then we have a rest of world protocol listed here. This is a 6-month-long trial with a 14.5-year long-term follow-up study as well. The primary endpoint, like all phase 1/2 studies, is to assess the safety and tolerability of EQR 506, and we're also monitoring for efficacy in this trial, as all babies need to be on a stable dose of nitrogen scavenger therapy, as well as they need to be protein restricted. We're going to assess the ability to wean these babies off of nitrogen scavenger therapy and to protein liberalize them as well. And we will also be monitoring VUN as well as the number of hyperammonemic crises that occur post EQR 506 administration. So for dosing, the only dose that we know that we'll utilize for sure is this low dose, which is 1.3 times 10 to the 13th gene copies per kilogram. Then after the first baby's dose, which he has been dosed, we have an independent data monitoring committee who will then assess based on the totality of the safety and efficacy data, whether to increase in dose or stay the same. So I'll get into this shortly, but our first baby did have a complete response to EQR 506. So the second baby that we will be dosing in the trial, we will be remaining at this low dose of 1.3 times 10 to the 13 gene copies per kilo. Inclusion criteria is listed here, so they need to be neonatal onset males. They need to weigh between 3.5 and 10 kilos at screening, have received all age-appropriate vaccinations, and have genetically confirmed OTC deficiency. And they also need to have a severe neonatal OTC deficiency, which is defined as experience a hyperammonemic crisis within the first week of life. So they need to have a peak ammonia level of at least 560 micromolar per liter. There's also in our ex-US protocol, if there is a prenatal diagnosis made and it's a known pathogenic variant and there's a prior family history as well, these babies can be managed from birth and can be dosed with ECure 506 prior to experiencing a hyperammonemic crisis as well. Exclusion criteria is listed here. So the contiguous gene deletion involving the OTC gene, these babies will be excluded from the trial as other organ systems can be affected within a contiguous gene deletion. This can confound some safety and efficacy data. So for our planned study locations, we currently have 2 study sites open in the US, in Los Angeles at UCLA and at Colorado, at Children's Hospital of Colorado. We should be having a couple other sites here open shortly in the US. In Europe, we have 2 clinical trial sites open in Spain, one in Barcelona and one in Madrid. And we also have clinical trial sites open in the UK, one of these being GOSH in London, and we have a clinical trial site open in Australia. So geographic location should not preclude eligible infants from participating in the study, say if there was a neonatal deficiency baby diagnosed in Egypt and one of you all were interested in referring for the trial. We would obviously pay for any travel assistance that these families need to get them to a clinical trial site for dosing. And then for the long-term follow-up study, we would be more than willing to work with sites within Egypt to set you all up as a long-term follow-up site because it's a long time, it's 14 and a half years, and just to ease the travel burden on these families. Now I'll get into our first infant dose data. So we did first dose the first infant in OTC Hope back in July. So this was a male infant born to a family with no prior history of OTC deficiency. He experienced a hyperammonemic crisis within the first week of life and was enrolled in the OTC Hope study. While he was enrolled prior to ECure 506 dosing, he did experience a hyperammonemic crisis at 3.5 months of age, in which the baby had undergone a stabilization period. Again, we were able to dose him at 6.5 months of age. The infusion was generally well tolerated. It was given over 1 hour. Post ECure 506 administration, we did detect asymptomatic grade 3 transaminitis at the infant's week 4 lab. So like we saw in the non-human primates, we did see transaminitis occur approximately 1 month after infusion. This was managed with immunosuppressive therapy, and the transaminitis resolved by week 8. The baby is now weaned off all immunosuppressive therapy as well. As far as post ECure 506 efficacy, after administration of ECure 506, the baby has experienced no hyperammonemic crises. He's approximately now 8 months post-dose and has not experienced any hyperammonemic crises. We were also able to discontinue nitrogen scavenger therapy 12 weeks post-dose and completely protein liberalize the child at 15 weeks as well. So the first subject has completed the 6-month phase 1/2 trial and is now enrolled in our 14.5-year long-term follow-up study. And our data monitoring committee has already met and approved the next patient to be dosed at the same low dose of 1.3 times 10 to the 13th gene copies per kilo. And this is indicative complete clinical response for protocol definition. So here you can see some lab results on the left-hand side. We are monitoring phosphoglutamine. So at approximately week 5, after administration of ECure 506, you can see glutamine levels were trending towards below the lower limit of normal to suggest that we were over-treating the child. So this is when a weaning of nitrogen scavenger therapy started to occur, which was completely discontinued at week 12. And then protein liberalization started shortly thereafter. Here you can see mean BUN levels, both pre-treatment and post-treatment. So this is an ECure monotherapy between weeks 13 and 24 after discontinuation of nitrogen scavengers have occurred. So you can see BUN has increased approximately 2.5-fold, and mean ammonia levels remain within normal limits as well. And again, these are EQ 506 monotherapy levels. So these mean plasma ammonia levels were taken between weeks 13 and 24. So an average mean ammonia level of 17.8 micromolar per liter. So in summary, OTC deficiency is the most common urea cycle disorder, and neonatal onset is the most severe form of disease. EQ 506 is an investigational gene insertion, gene editing therapy being evaluated for the treatment of neonatal onset OTC deficiency. We are utilizing a novel dual AAV platform to aid in the insertion of the OTC gene into the host genome to prevent episomal dilution, which I demonstrated earlier. It's currently being evaluated in a global clinical trial known as the OTCO trial. We have dosed the first baby at 6.5 months of age. Infusion was generally well tolerated. We experienced an asymptomatic grade 3 transaminitis within 4 weeks of onset, and this resolved within 4 weeks of symptom onset, within 4 weeks of detection of transaminitis cell maps. We're able to discontinue scavenger therapy and completely protein liberalize the patient as well. And the data supports continued evaluation of low-dose EQ 506 at 1.3 times the 13th gene copies per kilo. Thank you all for your time. Look forward to your questions later on. And if you have any questions at all, please feel free to reach out to me at twhite@eacure.com. Thank you for your time.
Thank you, Thomas, for this nice talk and giving hope to patients with inborn error of metabolism. The next talk.
Now I would like, it's my pleasure to introduce my dear professor, Dr. Mohammed Assawi, professor of pediatrics and medical genetics, and he's going to give us an interesting and updated talk about the landscape of epigenetics. Dr. Assawi, the floor is yours.
Bismillah ar-Rahim. My talk today is a message, just a message to parents and young generation to avoid abnormal environment and to be exposed to normal social media and avoid abnormal social media to be healthy psychologically and physically. ما بيغيرش. دي قالت لي دي يعني ادوس على دي. Our talk regarding epigenetics and homosexuality. Epigenetics means effect of environment on gene function with no change of DNA sequence. The environmental factors include family and social contribution, social media, psychological stress, diet, environmental pollution, for example, smoking, working on night shifts, physical activity, obesity, and alcohol. Epigenetics is responsible for genomic imprinting, genetic heterogeneity, uniparental disomy. الكلام يبان صعب لكن هو بالديفينيشن البسيط هيبقى سهل جدا. يعني ايه genomic imprinting؟ genomic imprinting يعني نفس الجين يدي اكشن مختلف في كل الاشخاص المختلفة. يعني المادة الوراثية بتاع البني آدم بالرغم ان هي نفس التركيب في كل البشر، نفس التركيب بالظبط، لكن وجودها في كل بني آدم بيشغلها بطريقة مختلفة عن البني آدم الآخر، وده بيعتمد على الانفايرومنتال فاكتور اللي احنا قلناها. يعني كل بني آدم يقدر يشغل المادة الوراثية بتاعته في اتجاه الخير وفي اتجاه الشر وفي اتجاه ياخد اكشن شذوذ وياخد اكشن طبيعي. هنثبت ده، وده كلام العلم مش كلام ماليش دخل بالدين، انا بتكلم بالعلم. ان كل بني ادم يقدر يشغل المادة الوراثية بالطريقة الصح او بالطريقة الغلط، وهل ده يرد على ان ممكن الانسان يبقى فعلا علميا مخير مش مسير لو خد بالاسباب الانفايرومنتال كونتريبيوشن المظبوط الهيلثي هيمشي في سكه صح، ولو مش خد بالابنورمال انفايرومنت هيمشي في السكه الغلط؟ ده وارد وفور ديسكشن، بس انا مقتنع ان ده اوكي فعلا. ده الجينيتيك هيتيروجينيتي العكس ان ديفرنت جين بتدي نفس الفانكشن، زي في الحالات اللي احنا قدامنا الاوتيزم، سيستيك فايبروزز، نون سندروميك هيرنج لوس، وبريدisposition تو بريست كانسر. اليوني بارنتال دايزومي دي يعني الاب والام، الفاذر والماذر، الماده الوراثيه بتاعتهم هي نفس التركيب، بس وجودها نفس الماده الوراثيه دي نفس التركيب لما تبقى موجوده في جسم البني ادم الفلاني تشتغل بطريقه، وهي في جسم البني ادم الثاني تشتغل بطريقه ثانيه. يعني الدي ان ايه والكروموزومات اللي موجوده في الفاذر بالرغم ان هي اللي موجوده في الماذر، لكن جسم الام يشغلها بطريقه مختلفه وجسم الاب يشغلها بطريقه مختلفه. فالدي ان ايه في الاب وفي الام والكروموزومات في الاب وفي الام بالرغم ان هما متشابهين لكن يختلفوا، يشتغلوا بطريقه معينه. الدليل العلمي ان كروموزوم 15 في الاب والام نفس التركيب، ده فور اكزامبل نفس التركيب بالظبط، لكن يشتغل بطريقه مختلفه في الام وبطريقه مختلفه في الاب. الدليل العلمي ايه؟ المفروض كروموزوم 15 فرده بتيجي من الاب وفرده بتيجي من الام، يطلع طفل طبيعي، يبقى فيه توازن. طب لو الفردتين جم من الفاذر، الكروموزومين 2 جم من الفاذر وطبيعيين، وده ياكد الكلام اللي انا قلته في الاول، والاثنين طبيعيين 100%، يديني مرض اسمه انجل مان سيندروم، اللي هو شايفين شكل الكلينيكال بتاعه ازاي؟ جيركي موفمنت وسترينج بابت وهابي بابت سيندروم، يعني كلينيكال بريزنتيشن مختلف عن اللي انا هقوله دلوقتي. طيب لو الاثنين كروموزوم جم من الناحيه الثانيه هم وطبيعيين، يديني البرادر فيلي سيندروم، انتلكشوال ديسابيليتي، اوبيزيتي، هايبوجينيتاليزم، سمول هاند اند فيت. يعني شايفين بالرغم ان الكروموزوم 15 هنا طبيعي وهنا طبيعي، بس عشان الفردتين جم من ناحيه واحده، يعني الاب والام او اي بني ادم بيعمل بصمه على كروموزوماته تؤدي ان هي تشتغل بطريقه لا يمكن ان تتشابه مع طريقه شغلها في اي بني ادم اخر. بس احنا هنا واخدين مثل الاب والام، الجينوميك امبرنتنج، ودي مقدمه عشان نوصل يعني دي مجرد مقدمه عشان نقتنع باللي انا هقوله في الاخر بالنسبه لموضوع الهوموسيكسوال. الهوموسيكسوال زي ما هنشوف في الصور دلوقتي نورمال جينيتاليا ونورمال فيريلايزيشن 100%، نورمال جينيتاليا ونورمال فيريلايزيشن وراجل مظبوط 100%، ملهوش دخل خالص. اهو شايفين الفيريلايزيشن ونورمال جينيتال، ده هوموسيكسوال، حد من الحالات اللي احنا شفناها ايام الدكتوره نعمه هاشم الله يرحمها، وهو واحده تانية هوريه لكم دلوقتي. فده مصري، يعني حاله شفناها من حوالي يمكن 40 سنه او حاجه. فنورمال فيريلايزيشن ونورمال ميل، ويتجوز ويخلف وكل حاجه، هنشوف مش ازاي بعد كده. ملهوش علاقه خالص بالدي اس دي ولا الهايبوجينيتاليزم، لان الدي اس دي يتعرف ازاي؟ الدي اس دي او الهيرمافروديتيزم ابنورماليتي في الاناتومي بتاع الاكسترنال جينيتاليا، بس لازم يكون في ديفكت في الاناتومي بتاع الاكسترنال جينيتاليا زي ما انتم شايفين كده. يعني اللي انتم شايفينها دي دلوقتي دي راجل اكس واي، يعني الكروموزوم الباترن بتاعها اكس واي، مش هندخل فيها، ده موضوع تاني. والهايبوجينيتاليزم جاست سمول جينيتاليا زي البرادر فيلي اللي احنا شفناها قبل كده. الهدف بتاعنا او الهدف اللي انا عايز اوصله من المحاضره دي انه الابنورمال انفايرومنتال فاكتورز اللي احنا قلناها، وهنعيدها تاني ونركز على حاجات معينه ممكن تخلي الهوموسيكسواليتي الوضع الحالي في البلاد العربيه ان هي سايلنت، يعني مش واضحه زي بره، تقلبها من سايلنت كريبنج ابيديميك الى ابيديميك. في مثال تاني صحيح حصل قبل كده، سنة 2006 كنت عامل مؤتمر عن الاوتيزم وكان عنوانه اوتيزم سايلنت كريبنج ابيديميك، بنفس النمط ده. استنينا ما ناخدش بالعوامل البيئية اللي تساعد ان الطفل الطبيعي يبقى اوتيزم لغايه ما بقى ابيديميك. دلوقتي احنا بنشوف حالات، يمكن بنشوف حالات دلوقتي اوتيزم كل سنه بتزيد عن السنه اللي فاتت، لان احنا ما خدناش بالانفايرومنتال فاكتور. الطفل الجبله ما يجيلوش توحد، الطفل الراقي الحساس لو ما لقاش طبطبه وبوس وحضان وخروج وفسح وملغيه وجو عائلي مبهج ورومانسي ولقى خناقات وزعيق والكلام ده كله، يقلب على سنه ونص الاوتيزم. فالانفايرومنتال كونتريبيوشن يشغل الماده الوراثيه في الخير ويشغلها في الشر، ويشغلها نورمال ويشغلها ابنورمال. الانفايرومنتال كل واحد لو اشتغل على الماده الوراثيه واهله ربوه ان الانفايرومنتال كونتريبيوشن المحيط بيه هيلثي، مش هيطلع عنده مشاكل. فهدف التوك النهارده ان احنا نتناقش مع بعض ونقتنع انه لو انا وفرت نورمال انفايرومنت في التربيه مش هيبقى عندي حالات هوموسيكسوال. والسوشيال ميديا من اهم الحاجات اللي بتساعد على تشجيع الهوموسيكسوال زي ما هنشوف دلوقتي. تو كونفيرم الكلام اللي انا بقوله ده، هنتبع ساينتفك فاكت في الامبريولوجي والاناتومي والابيجينيتك عشان ناكد الكلام بتاعنا. بالنسبه للامبريولوجي والاناتومي، في الانتراتورايل لايف في الاسبوع السابع بيبقى عندي اندفرنشيتد جوناد وتو داكت سيستم. في حاله الميل لو الكروموزومال باترن اكس واي، الاندفرنشيتد جوناد هتتحول الى تستيكل، والتستيكل هتعمل فيراليزيشن تطلع تستوستيرون وتطلع موليريان انهبيتوري فاكتور. الموليريان انهبيتوري فاكتور ده مهمه، ده بيت القصيد. اذا ما لقاش environmental contribution normal الفيراليزيشن ما يشتغلش. يعني التستيكل نورمال والتستوستيرون نورمال وبيطلع الموليريان الميل انهبيتوري الميل امبرنتنج بيطلع، مش الموليريان انهبيتوري بيطلع الميل امبرنتنج عشان يعمل ميل امبرنتنج. لو الميل امبرنتنج ده الولد ما ترباش كراجل وتربى له قصه وتحط له احمر في ضوافره وتقال له يا سوسو، الميل امبرنتنج ما يشتغلش ويقلب بعد كده على هوموسيكسوال. فالتربيه الاولانيه كل اللي ما خلق له، مع برضو ان انا ما بحبش اخد براهين من الدين، لان العلم حاجه والدين حاجه تانية. لكن يعني علميا لو اتربى بطريقه غلط هيطلع هوموسيكسوال. اقدر امنع الهوموسيكسواليتي بالطريقه اللي احنا هنقولها دلوقتي، مش حكايه ان هو هيومن رايتس زي ما هنشوف، وزي ما هنشوف كلام لحتى لترامب وبعض منظمه الصحه العالميه بيقولوا نفس الكلام اللي انا بقوله ده، بس التغطيه عليه جامده. بالنسبه للابيجينيتكس بقى، الابيجينيتك اند هوموسيكسواليتي، الابنورمال رول اوف سوشيال ميديا لما يطلع في السوشيال ميديا كل الاربعه دول هوموسيكسوال. وشايفين الفيريلايزيشن هنا عند الراجل اللي لابس عقال ده فيري جود، يعني نورمال فيريلايزيشن، دقن وشنب وجينيتاليا مظبوطه وكله مظبوط. لكن اتعرض بقى لسوشيال ميديا، وده من السوشيال ميديا بس انا مخبي الاسم، ان دي بقى بييجوا يقول لك ان احنا عاملين مسيرات الفخر، يعني احنا فخورين بنفسنا واحنا ناس عظيمه، وبيودي ثقافه للناس ان ده حريه شخصيه، وان ده لا، ده مش حريه شخصيه، ده شذوذ، مش حريه شخصيه خالص، ولا هيومن رايتس، ملهاش دخل بالهيومن رايتس بالمره. يعني اهو اكتر من مجرد احتفال ومسيرات الفخر. فبالتالي بالرغم ان هنا كومبليت فيراليزيشن، بيقولوا في السوشيال ميديا انه السكشوال ديزاير فور ميل مش محتاجه فيميل، ده الثقافه بتاعتهم. وده غلط، يعني ثقافه غلط، مش حريه شخصيه برضه. وزي ما انتم شايفين دول كلهم هوموسيكسوال. حد يصدق ان ده راجل؟ ده اللي انا شفته وانا والدكتور مدحت الشافعي اللي كان الله يرحمه، اللي كان الحالتين دول انا والدكتور مدحت شفناهم يمكن برضو من حوالي 30 40 سنه. حد يصدق ان ده راجل؟ اهو خد هرمون بس عشان تكبر البريست، راجل 100%. وكان جايب معاه ده في بدايه السكه وده في نهايه السكه. فيبقى هنا لا، لو كان اتربى بانفايرومنت هيلثي كل اللي ما خلق له، الراجل يتربى كراجل ليس انتقاصا من حق حد، والبنت تتربى كبنت ليس برضو انتقاصا من حق حد، ما يبقاش عندنا هوموسيكسواليتي. يعني نقدر ناخد اكشن دلوقتي لثقافه وعشان نمنع الحاجات دي ما تبقاش زي التوحد اللي سبناه لغايه ما بقى فعلا حالات شديده جدا. هل هنستنى نايمين لغايه ما يجي لنا مجموعه كبيره من الناس ويبقى ده حقوق الانسان ويجي لنا العالم كله يقول لك سيبهم دي حريه شخصيه؟ المفروض ده بايدينا بقى وزاره الصحه. وزاره الصحه انت اللي مسؤوله قدامي. ايوه، وزاره الصحه مسؤوله ان هي تعمل الشغل ده. يعني نورمال بيبقى في وجود نورمال امبريولوجي اند اناتومي، لكن في وجود ابنورمال فاميلي اند سوشيال كونتريبيوشن وابنورمال رول اوف سوشيال ميديا وسايكولوجيكال ستريس هيجي لي ابنورمال انديفيدوال هوموسيكسوال. لكن في وجود النورمال هيطلع لي نورمال طبيعي. للفيميل بقى ريجاردنج الامبريولوجي في الاسبوع السابع من الانتريوترايل لايف الاندفرنشيتد جوناد وتو داكت سيستم في وجود الاكس اس هيتعملوا اوفريز، ويتعمل بقى هيتعمل الفيمينايزيشن بالطريقه الطبيعيه. الابي جينيتكس بقى دوره ازاي؟ الابنورمال رول اوف سوشيال ميديا. دي ست مكتمله الانوثه راحت للسوشيال ميديا وقالوا لها السكسوال ديزاير دونت نيد ايميل، وثقافه عاديه لا مش اهو العاده السريه لدى نشوه لا تحتاج لرجل. معترضه؟ لو معترضه نبطل. اوكي. وطبعا الخواجات بيزعلوا من الكلام ده جدا، يعني الكلام ده لو اتقال بره ممكن يعني يسجنوا اللي بيقوله، لان يقول لك ده حريه شخصيه. وهنشوف دلوقتي منهم اللي بيقول لا ماشي مع الراي بتاعي، بما فيهم ترامب بيقول نفس الكلام اللي انا بقوله دلوقتي. نيجي بقى عشان تو ميك ات شورت، يعني انا اللي يهمني ان كونكلوجن، هل اقدر امنع الهوموسيكسواليتي؟ نحتاج وزاره الصحه تعمل بريماريتال اديوكيشن بالنسبه للانفايرمنت، كل اللي ما خلق له، الولد يتربى ازاي والبنت تتربى ازاي، ليس انتقاصا من حد، لانه لو ربنا عايز يخلق جنس واحد ما كانش خلق ميل وفيميل. هم ربنا خلق الراجل نص والست نص، النص ده بيعمل حاجات النص الثاني ما يعملهاش، والنص ده بيعمل حاجات النص الثاني ما يعملهاش. لو الاثنين جمعهم سكن وموده ورحمه وتسامح يبقى ده نعمه من نعم ربنا الكبيره، بيتكاملوا مع بعض ويعملوا كيان واحد. دي الطبيعه والفطره السليمه. الهوموسيكسواليتي والهيومن رايتس اللي هيرد عليها الفيديوهات اللي جايه دي. لو تشغلوا لي الفيديو يبقى كتر خيركم. يعني اسمعوا بقى اسمعوا الكلام اللي انا قلته بالظبط. منظمه الصحه العالميه بتقول ايه، وبعدها ترامب، وبعدها حد من الاذاعات الخارجيه. حاضر. لا هنقول الثلاثه بسرعه، كل واحد دقيقه. انا كنت عايز اكمل، فالدكتوره علا قالت لي لا تخلص فورا عشان الناس متضايقه ومش عايزينك تكمل، فعشان كده مش هكمل. اوكي. هم اللي معطلين اهو، ماليش دعوه، المهم يشتغلوا. انا خلاص يعني بالفيديو كنت ناوي اتكلم على حاجات تانية، لكن يعني خلاص دي ال3 فيديو كل فيديو دقيقه، اسمعوه عشان تقتنعوا. مش احنا بقى حتى الخواجات المحترمين بيقولوا كده. انا بعت الفيديو ده من 10 ايام عشان يشتغل. قلت عشان ما ياخدش وقت.
هو جاهز المفروض يا فندم، وهم شافوه ان هو شغال زي ما بعت لحضرتك.
بس يهو يشتغل هنا. انا ما فيش كلام بعد كده، هي الفيديو وخلاص نخلص. اوكي، الله يخليك.
طب ممكن حضرتك تقول لنا الكونتنت بتاع الفيديو على ده؟
الايه؟
الكونتنت بتاع الفيديو على احسن ما يشتغلش.
في مشكله ولا حاجه؟ هم شغلوه بره. على الواي كروموزوم.
وقالوا ده اصلا هو ده اللي بيتحكم في الدايركشن بتاع الميل.
لا، هي كلها مالتي فاكتوريال. يكتب زي ما عايز، لكن هي كل الامور مالتي فاكتوريال، جينيتك انفايرمنتال. يعني في حاجات، يعني يعني مثلا خد البوليومايلايتس، الفيروس لو دخل وما لقاش الكروموزوم نمره 19 عليه البوليو فيروس سنسيتيفيتي جين ما يشتغلش. بس تكلفه ان انا اقعد اشوف مين اللي عنده الجين ومين اللي ما عندوش اغلى بكتير من ان انا اطعم كل الناس. فهتلاقي في الاخر كل الامراض اللي في الدنيا جينيتك انفايرمنتال، واختلاف مرض عن مرض البرسنتج اوف جينيتك كونتريبيوشن للانفايرمنتال كونتريبيوشن. اشتغل؟ يشتغل، بس انا مش هتكلم، هو يشتغل بس. واسمعوا كويس الكلام، بيقول نفس الكلام اللي انا بقوله، ومن ناس مسؤولين، يعني منظمه الصحه العالميه. ده ترامب الاول. وده الصحه العالميه.
American Medical Association has announced that the sex of a child should not be on a birth certificate because we don't know it until they choose. This is the American Medical Association.
Can you pull this up?
Yes, pull it up.
The American Medical.
Yes, the American. See, this is the thing. People don't know the damage the left does to everything it touches: art, music, education, children, male-female relations, and medicine. It has corrupted the medical field. The American Society of American Academy of Pediatrics, or pediatricians, whatever the full name is, they've come out for affirmative care to give minors hormone blockers. I mean, that is evil. American.
The left-wing gender insanity being pushed on our children is an act of child abuse. On day one, I will revoke Joe Biden's cruel policies on so-called gender-affirming care. Ridiculous. A process that includes giving kids puberty blockers, mutating their physical appearance, and ultimately performing surgery on minor children. Can you believe this? I will sign a new executive order instructing every federal agency to cease all programs that promote the concept of sex and gender transition at any age. The Department of Justice will investigate Big Pharma and the big hospital networks to determine whether they have deliberately covered up horrific long-term side effects of sex transitions in order to get rich at the expense of vulnerable patients, in this case, very vulnerable. We will also investigate whether Big Pharma or others have illegally marketed hormones and puberty blockers, which are in no way licensed or approved for this use. My Department of Education will inform states and school districts that if any teacher or school official suggests to a child that they can be trapped in the wrong body, they will be faced with severe consequences. I will ask Congress to pass a bill establishing that the only genders recognized by the United States government are male and female, and they are assigned at birth. The bill will also make clear that Title IX prohibits men from participating in women's sports. No serious country should be telling its children that they were born with the wrong gender, a concept that was never heard of in all of human history. Nobody's ever heard of this, what's happening today. It was all when the radical left invented it just a few years ago.
I was talking to a man the other day who was leaving this leaving this country. And I said, why are you leaving? He said, it's homosexuality. I said, what are you talking about? He said, 300 years ago, if you were homosexual, you were hanged, drawn, and quartered. 100 years ago, if you were homosexual, you were hanged. 50 years ago, if you were homosexual, you were flogged and given 20 years in prison. 20 years ago, if you were homosexual, you were fined £200 and sent to prison for 2 years. 5 years ago, if you were homosexual, you had a small fine and you were pardoned. Got off with a warning. I said, well, what are you leaving for? He said, I'm going before they make it compulsory.
شكرا شاكرين.
Thank you, Professor. Thank you, Professor Sawi, for this talk. And we have a question from Dr. Ahmed Rami. And Dr. Izzat Al-Subki and Dr. Thomas are online if you need question. I have a question for Thomas. Thank you, Thomas, for this lecture. If there is any hope for any other inborn error metabolism to do gene editing? Dr. Thomas White.
Good morning.
My question is, if there is, thank you for giving hope to OTC patients, but if there is any more in the future for other inborn error metabolism, gene editing for other inborn error metabolism?
Yeah, it's a good question. So through our partnership with the University of Pennsylvania, we have the rights to evaluate this dual AAV gene editing technology for citrullinemia type 1 and also for phenylketonuria. Realistically, if assuming this clinical trial goes well and we prove the safety and efficacy in OTC males less than 9 months of age, we then plan to expand out to include OTC patients up to 2 years of age and include female patients as well. So I guess next on the horizon is expanding this patient cohort with OTC deficiency up to 2 years of age and include female patients. And then we will likely start bolstering the citrullinemia type 1 program. And we also have the rights to evaluate this for PKU.
Thank you. Dr. Izzat, are you online? Dr. Izzat Al-Subki? Dr. Ahmed.
Yes, Dr. Ashraf, I'm online.
Thank you for the talk. I just want to ask if PGT will be applied also for Fragile X and other trinucleotide repeat expansion.
Yes, I think we first confirm before offering the PGT-M for those disorders you mentioned by the setup. If the setup is successfully giving us back results that we can detect the abnormal variant or expanded or pre-mutation within this family by preclinical setup, then we go and offer embryo testing. That's why in those cases, we ask the family and counsel them. We have to have blood samples from the kids, from the parents and grandparents, and then we do the preclinical testing using the specific markers around. And if we come out with possibility of 95% to detect the high risk and low risk haplotype, then we ask them to go for ICSI and to test the embryos. If we failed or the sensitivity dropped down to like 80, 85, we recounsel them before testing, and if they accept, they have to sign a consent form that we have explained everything to the family, and they do agree for offering PGTM with such a lower sensitivity.
ثانك يو جمال. الحقيقه انا ليا سؤال للاستاذ الدكتور محمد الصاوي. هو يعني انا تذكرت يا فندم هساله بين حضرتك ليك سؤال؟ عايز اسال الدكتور عزت بيه حضرتك موجود؟
موجود يا فندم.
طيب اتفضلي.
دكتور عزت ازي حضرتك؟ انا دكتوره مها سعد زكي، ازيك عامل ايه؟
اهلا دكتوره مها، ازي حضرتك؟
اهلا بحضرتك. انا كنت بسال بالنسبه للبرينيتال دايجنوزيس او البي جي دي للفيش سكابولو هيومرال، علشان هو بيبقى دي 4 زد 4 اللي بتبقى موجوده بتبقى ريبيتس معينه موجوده، بس انا عشان عندي حالات فكنت سالوني السؤال ده بس انا ما عرفتش ارد، اللي هو الفيش سكابولو هيومرال اللي هو الاوتوزومال ريسيسيف 4. هل بنبقى نعمل له برينيتال دايجنوزيس؟ لان طبعا حضرتك عارف ان هو اوتوزومال دوميننت، فطبعا ريكارنس كلهم كبار في السن عاوزين يتجوزوا يعني او متجوزين، فسالت السؤال ده فانا بس حبيت اعرف لان انا بحثت فيه فما عرفتش.
طيب.
شكرا.
العفو. Excellent. I think the same answer of the Fragile X and triplet repeat. It's better to collaborate and offer one of your family preclinical setup and to test the sensitivity of the markers to make sure that we will be able to detect the high risk haplotype to exclude them while embryo testing. And actually, recently, things are going to a very complicated problems that if you have a case of Huntington disease, then if the grandfather died from the disease, then the father actually don't want to know if he carried a variant or not, and he wants to have a normal offspring. So you have to offer PGTM while you will not tell the father if he is not carrying the gene or not, and to make sure that when you release your reports saying that this is a normal, without telling the father that he is not carrying the gene or not. So actually a challenging points in PGTM is coming up with this PGTM technology. But still, as you have asked, we have families that we have to work together to make sure that we can offer those families PGTM successfully.
Thank you. معلش انا اسف استاذ دكتور محمد الصاوي. انا تذكرت بيت الشعر بتاع على قدر اهل العزم تاتي العزائم. ما حدش يقدر يدي المحاضره دي غير حضرتك، ما حدش عنده الشجاعه انه يديها غيرك. فانا هسالك بقى برضه، انا عندي الشجاعه هسالك بقى اسئله كتير قوي. طبعا احنا في التجربه بتاعتنا الممارسه كلينيكال مع الناس دي صعبه جدا. يعني من الصعب جدا، لسه الدكتوره سلاف بتفكرني في المركز كان في واحد جاي مصر ان هو بنت وقاعد يروح ويجي وهي تبعته لي وانا ابعته لها. التعامل معاهم صعب جدا. انا في البرايفت براكتس بتاعي ما زلت اذكر عيانه، هي مش عيانه، هو عيان اكشولي، هو راجل جاي لي وشكله غريب جدا، عضلات كده زي ما الدكتور محمد رسمه، حاطط مانيكير في ايديه بطريقه زي الاطفال الصغيرين لما بيحطوا المانيكير كده، وايديه ايدين رجاله، وعنده دقن حالقها جامد بس خضره، وما عندوش بريست، ومطول لابس باروكه ومطول شعره. حتى البنت دخلت تقول لي في عيانه بره، هي مش عارفه تتعامل معاه. اول ما دخل عندي اسمه جيسي، مسمي روحه جيسي، وعايش، هو عراقي وعايش في دبي. انا مش فاهم ايه، انا جاي عشان بدي هرمونات. انا مش عارف اتكلم معاها، يعني اقول لها انت ولا اقول له انت. انا بقيت مخضوض. يعني اول رد فعل هيجي لك لما تتعامل مع الناس دي انك بتتخض، انت مش عارف تتعامل معاه، هو راجل ولا هو ست. انا عملت اوركيتكتومي وهعمل اوجمنتيشن ماموبلاستي ايه الكلام الغريب ده؟ انا بقيت عايز يعني خد يا عم كشف وامشي، مش عايزك عندي يعني. وبعدين شابهني في العياده، كل اللي قاعدين بره ايه المنظر كل الناس قاعده تبص، كل واحد يخش يسالني هو ده كان عنده ايه، او دي كان عندها ايه، ودي كان عندها ايه. ف الدكتور محمد النهارده وضح لنا شويه قصه. طبعا احنا هنشيل على جنب الدي اس دي اللي هو ديس اوردر اوف سيكشوال ديفلوبمنت، دول غلابه. ودول يعني دايما السؤال اللي كان بيجي لي مع الناس دي، دول يورثوا ازاي؟ معرفش، لو حد فيكم يعرف يبقى يقول لنا. يعني يورث راجل ولا يورث ست؟ لان دي اعتقد بالنسبه لنا احنا في مجتمعنا بتختلف قوي. يعني هل هو يورث كذكر ولا يورث كأنثى؟ يعني هل هو الجينيتك 6 هو اللي هيورثني ولا الفينوتيبك 6 اللي هيورثني؟ اكيد الدكتور محمد عنده المعلومه دي. دي حاجه الثانيه بقى اللي عايز اسالها، الابيجينيتكس دي. يعني هو دلوقتي انا تخيلت يا دكتور محمد بيه ان الناس دي ضحايا مش مذنبين. دكتور عوض تاج الدين شرفنا اهو. طيب
السلام عليكم. هي طبعا زي ما الدكتور احمد رامي قال انه العيانين دول بيبقوا فيري اجريسيف، وانا هضرب مثالين بس. في عيان اسمه مدحت كان مسمي نفسه مديحه، وكان جالنا في عياده الوراثه ايام الدكتوره نعمه هاشم الله يرحمها، ولما الدكتوره نعمه هاشم قالت لا ده يروح امراض نفسيه وكذا، دخل عليها لولا احنا حشناه كان هيموتها. يعني فعلا بيبقوا اجريسيف جدا. في عيانه تانية من الصعيد كانت برضو عايزه تبقى راجل، واحنا قلنا لها لا، راحت لعمرو نوير واستنت عمرو، برضو عمرو رفض يعمل لها الجراحه، استنته تحت ورمت عليه ميه نار، الحمد لله جت على الجاكيت بتاعه بس ما حصلش مشكله. فدول بيبقوا اجريسيف جدا 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 جدا. لكن هي في اليابان بيدوا الام اجازه مدفوعه الاجر اول ما تحمل، ويسمعوا الجنين داخل بطن الام بعض الحاجات لرفع قدراته الادراكيه. تربيه الطفل بتبتدي ان يترو. فانا بس كل اللي ما خلق له، لو ربيت الولد كولد والبنت كبنت من الاول خالص مش هيحصل مشكله، بس على شرط السوشيال ميديا والمجتمع ووزاره الصحه تعمل زي احنا بنشوف دلوقتي العيال الصغيره عاملين كحكه كل ده مش صح. هيقول لك ايام الرسول كان كذا، ايام الرسول كله كان مطول شعره. فزي المجتمع ما حواليك، لانك انت هتبص ممكن لو لقيت المجتمع مختلف عنك هتتلخبط. فهي دور وزاره الصحه ان يعمل اورينتيشن للموضوع ده. عشان الوقت كده.
Thank you, Professor Muhammad. We came now for the end of our first session, breaking barrier, bleeding bridges, and inborn error of metabolism. Thanks great for the chairpersons, for the speaker, and for the audience. I want to tell that Nutricia team is always supportive to the metabolic products and also metabolic diseases. And in a brief 10 minutes, they will update us with the most recent in their product. Please, Dr. Ahmed, the floor is yours.
Thank you. Yes. All right. Thank you, Dr. Ola, so much, and thanks for all the chairpersons. Thank you, doctors, for your coming today and for your time. First of all, I want to introduce myself. My name is Ahmed Ali. I'm the senior brand manager for the metabolics and for epilepsy in Nutricia. I want to start my presentation by actually focusing on your parenterals for life. We know most of the metabolic infants or metabolic patients, they will have the problems from their infancy, and that will continue through their toddlerhood and then all over the life. So in Nutricia, we are determined to provide solutions, nutritional solutions for these infants, for these patients, from day one until their later life. So what about our mission? So in Nutricia, we want to be a partner for life with these children or with these infants to help them to reach their full potential and to reach the normal life that they deserve. All right, so how we're gonna do that? Of course, we have an optimum nutritional solutions for many of the metabolic diseases in the Middle East. So of course, in Egypt mainly, we have more than 120 years of experience, more than 600 presentations, and of course, we have a complete portfolio of products and services to help these patients or to help these infants. What are the services that we are proud to support or to serve? Of course, number one, we can support, of course, with Dr. Nanis and Dr. Hala in the newborn screening in Egypt and in many other countries through providing consultancy and providing trainings when required. Second thing, of course, is the doctors' educations or HCP educations, since, of course, doctors are the primary focal points for these patients. So we are focusing, engaging in scientific conferences like this conference. We have our own standalones like the Metabolic University. We have other engagement with the HCPs to support them when dealing with these difficult cases. This is one example of the metabolic clinical kit for the doctors at the metabolic centers to aid them or to serve them with the simplified materials for the diagnosis and for the management of the rare metabolic diseases. And also this is like a checklist for also doctors at the clinics or at the metabolic centers to give them the opportunity to deal with these patients or with these infants. All right, so we are talked about the physical engagement. Of course, we have another way of engagement with which is the online engagement. We are serving doctors with either web applications or mobile applications or calculation for the doses like the PKU calculator or rare metabolic disease calculator. And of course, all these tools, we are empowering doctors to treat these cases efficiently as much as they can. Regarding the patient education, we have a full team of patient educators. We call them the Hope Ambassadors. Actually, these patient educators are found all over Egypt, from Cairo to Upper Egypt. And their main role is to support the doctors at the metabolic centers, support the moms. Of course, they will have tons of questions regarding the infants, regarding the children. So our patient educators are always there, are always ready to answer any question or to clarify any problem in the diet or anything. And of course, we have educational materials, we have patient days, and we have metabolic kitchen to engage the moms in preparing food or preparing recipes for their infants or for their children. Of course, this is the portfolio of Nutricia in Egypt mainly. We have for the PKU, we have PKU 1, 2, and 3, and we have products for other metabolic diseases that are present in Egypt. Of course, these are mainly the metabolic defect or the metabolic diseases that we are working with, and we have a portfolio for. Of course, we are focusing on the Anamix range. Anamix range is supported with the prebiotics and supported with the LC-BUFAs, DHA, and ARA. It's for birth until 12 years. And then we have the Maximade range. It's from 1 year up till 8 years. Of course, we are dealing in MSUD, MMA, PA, and GA, HCE, and tyrosinemia TIR. With that, of course, we are continue our support for the metabolic ecosystem in Egypt and all over the MENA region. And I'd like to thank you all for your support and for your efforts to make these lives or make the lives of these children much better. Thank you so much. Thank you, Dr. Ala.